So I will be presenting on the prevalence and consequences of drug-drug interactions in older adults with cancer. So my talk will be focusing on the high prevalence of drug-drug interactions, which is likely attributed to polypharmacy, which is a common term that we've heard thus far at the meeting, and also attributed to comorbid conditions that disproportionately affects older adults. So between polypharmacy and increased comorbidities, this increases the number of medications that patients are on, which then increases their risk for potential drug-drug interactions. So simply put, drug-drug interactions can be defined as a pharmacologic or a consequence in which one drug can affect the therapeutic level of another drug. And in many instances, this can lead to harmful side effects. But there are cases where these interactions could be of benefit to patients. So one of the studies that I will be presenting is looking at the increased prevalence of drug-drug interactions, particularly between acid suppressive medications known as proton-pump inhibitors, which are quite prevalent in older adults, and small molecule tyrosine-kinase inhibitors, which are oral cancer drugs that are used for a variety of malignancies. One example would be a drug called erlotinib, which is commonly used for lung cancer. So this particular paper that I will be presenting is talking about how there is an increased prevalence of use of proton pump inhibitors, which actually inhibits the absorption of many of these small molecule tyrosine kinase oral cancer drugs. And this study is showing an increased risk of mortality between the fact that these two combinations are quite prevalent use. So the study talked about a prevalence risk of about 22%, which is actually quite alarming, knowing that 22% of this population is using two drugs in which one drug inhibits the absorption of the other drug, meaning that there's going to be reduced efficacy of that anti-cancer drug, which then can be linked to now mortality. So I think we have more data showing not only the prevalence, but now we are starting to have emerging data talking about some of the consequences associated with these drug-drug interactions. I think that one of the newer areas of research is going to be how do we screen for these drug-drug interactions. So there are quite a number of clinical decision support tools that are built into electronic health records to be able to screen. But what we're noticing is that many of these different screening tools actually provides different levels of information. So now we have a little bit of variety or heterogeneity in terms of what is being reported and how each of these interactions is actually being classified. So that kind of increases a little bit of discrepancy or inconsistency depending on which tool is actually used to screen for drug-drug interactions. So that's a great question. Well, I think that one of the next steps is really to make sure that we know what medications patients are taking, because no matter what type of clinical decision support tool an organization has, if there are drug omissions, then that's going to decrease the reliability of that tool. So I think one of the things that we have to do is make sure that we have thorough and adequate medication assessments so we know what medications patients are taking, not just prescription drugs, but also non-prescription drugs, as well as herbal supplements, because there are increasing rates of interactions between medications as well as herbal supplements. So the next step is to make sure that we are able to utilize these clinical decision support tools, and that also that we incorporate our pharmacist colleagues in terms of being able to review that information to determine, I think, the clinical significance and the clinical relevance of these interactions. So kind of bringing in other allied healthcare providers into the mix to be able to help physicians and to help patients understand the severity of these interactions, the relevance, as well as the significance. So I think that those are some of the next steps to be considered. Well, the one thing I will say, I think that there is emerging evidence that is actually looking at pharmacokinetic guided dosing adjustments, and I think that perhaps that is an avenue of research to be considered, since many times when it comes to oral cancer drugs, we use a one-size-fits-all approach, and there is emerging data to suggest that if we actually assess patients' blood levels by doing pharmacokinetic studies. If patients are exposed to drugs that can alter their drug levels, this would be able to be detected by basically doing these pharmacokinetic guided dose adjustments. And there's an emerging body of literature that actually has utilized this process for a variety of oral cancer drugs. And perhaps this would be a way to offset some of these potential drug-drug interactions, because we will be actually able to look at a patient's drug level to see if their levels are too high or if they're too low, which obviously would affect efficacy as well as toxicity. And we can then do dose adjustments based on this. So this is, I think, a newer area of research that is to be considered, especially given the rising cost of a lot of these oral therapies. To have patients on a drug that can interact with the drug and decrease its efficacy is less than ideal. So I do think that there is an emerging body of evidence to suggest that we could perhaps be doing more when it comes to therapeutic drug monitoring and doing dose adjustments to ensure that patients' drug levels are within the therapeutic range. So no. So I would probably say no, since I think that therapeutic drug monitoring is quite universal. It's something that is done for a couple of other drugs that are non-anti-cancer drugs. So I don't think that that is necessarily specific to geriatric populations. However, I do think that given some of the issues with drug-drug interactions, that is a population that would be able to benefit, because many times if these patients are on medications that interact, we kind of really don't know if those patients are within a therapeutic range outside of just looking at or assessing whether or not they're experiencing toxicity or if they're experiencing tumor progression. So we kind of have to use those metrics to then figure out if the patient's drug levels are too high or too low. So perhaps this is an opportunity where we can use a more tailored approach for this population.